Good evening, friends. Let's begin our 141st webinar, second of the one with cases and some tips. These tips I have picked up. I was going through my DNB notes, which I had made in 92 to 94. So I picked up some tips because we used to have multiple questions, multiple choice questions. So I thought I'll share with you all because they are really helpful in practice. Cases may seem simple cases, but each case has taught me something. So without wasting much time, let's begin case one. This is a story of 1995. An 85-year-old female, no hypertension, no diabetes, no dyslipidemia, no regular treatment except calcium and multivitamins. She was a sick female, SIKH, and she was very active. She used to do all the housework, including cooking for her grandchildren and children. She presented with a very unique complaint, which actually fogged me initially. Uncontrolled, involuntary, aimless movement of the left upper limb as if it's acting on its own will. I will show it to you. She came to the clinic. She was a very smiling lady and her hand was like this. And she's talking to me. So I asked her, why are you moving hand like this in Hindi? She's saying, I'm not doing it. It's happening automatically. This truly puzzled us. As if it was a useless hand. As if being under the control of someone else. What appeared as the passive movement of the hand were actually active movements. Started gradually 3 days back. But she thought something wrong with the way I sleep and all. But they came around 11:30 in the morning, and since morning it was continuous. Whole day. Pulse 84 per minute, regular, BP 138/82, RR 18 per minute, SpO2 96% on RA, ECG within normal limits except low T in inferior leads, which was expected with their age. Neurological, cranial nerves, nothing abnormal detected. Power in all 4 limbs, 5/5. Tone, no hypotonia, no hypertonia. Reflexes normal. And even if you try to hold the limb down, it will remain down, but the minute you leave it like a spring, it will bounce back. With great difficulty, CT scan brain was done. 1995, doing CT scan brain was not an easy task. Convincing people, asking them to spend so much money. I was suspecting an SOL somewhere in the parietal lobe. I'll tell you why I thought of parietal lobe. Because I had just finished my DNB and neuroanatomy was clear in my mind because we had a group of doctors and we had solved some 25,000 to 30,000 multiple choice questions. I knew parietal lobe, a certain part controls the movement of the hand, and I thought there could be a space occupying lesion sitting there. It showed a subdural hematoma sitting on the parietal lobe on the right side. Opposite side limb was behaving funny. And we kept asking her what happened, any trauma. She's saying, I have not left the house in last 6 months. She was staying on 3rd floor, no elevator. And she said, I have not gone out of the house. Then suddenly she remembered 3 weeks prior to this episode, she was sitting down under the tap taking bath. As she got up, her head hit the tap. And that is where the upper limb part comes. This is the head and this is the midline, and it would have hit somewhere here when she was getting up from sitting position while bathing. See this. This is the parietal lobe, that is the motor cortex, and this whole part represents the upper limb. And the subdural hematoma was pressing on that. On the other side, again, I have taken a picture which I have shown. Arms and thumb. She was admitted at KM hospital because those days other hospitals were very expensive. They were middle class family. And when she was operated, the neurosurgeon gave me the clue that this is called the useless limb of parietal lobe. I have done some Google search and it is known as an alien hand syndrome, AHS, defined as an involuntary movement of the hand as if acting on its own will or as being under control of someone else. The affected hand typically does not show any sign of weakness or convulsive movement, no tremors. The cause is associated with an insult to the brain from various conditions such as a stroke, trauma, tumor, aneurysm, any neurosurgical intervention, some infection, some abscess, and maybe a degenerative brain disease involving that part only. So what this case taught me was, we should always remember which part of the brain is represented on the surface of the motor cortex, and the deficit of function of that part can tell you without even an MRI which part of the brain has got a stroke or a pathology. Case 2. I have a practice from my first day. I never examine any patient sitting. Many doctors in busy schedule examine the patient sitting. They even palpate the liver in sitting. No, I have a rule that every patient has to lie down, and over a period of 46 years, that has paid rich dividends to me. This case, of course, is not that position of lying down. This case is of 10 days back, 18th July 23, 11:20 a.m. 15-year-old girl, first time ever visit. She has never come to me before. Even the family that brought her had never come to me before. They were staying in the next building. Sudden severe pain in right eyelid fossa since 5 minutes. One vomit, she was howling with pain. I was inside my cabin and I came out hearing the howling with pain. She arrived 2 days back from Dubai. So my first question was, Did you eat out? Because I was suspecting a GI infection. No, no history of eating out. No bleeding PV. She was 15 years, menarche from 13 age, LMP 29.6. And 29.6 to 18 July was 20 days. So I asked her about any history of dysmenorrhea. No. Then the second question, she was not sexually active. This required a lot of sensitiveness to ask the question in front of the relatives who had brought. There was only one male relative. I couldn't keep him waiting out and ask this question to her. So I first told him that I am sorry, I'm asking a very sensitive question in front of you because you are the only relative. I kept my female assistant next to me, not a medico. And we asked her and she said, no, I am not sexually active. So she was tachycardic, 118 per minute, BP 120/90, slight rise of diastolic, and tachycardia suggested that this is truly an acute abdomen. And an emergency ultrasound was asked. Locally, there was tenderness in right iliac fossa, but it was not the tenderness that we experience with appendix. It was somewhere between RIF and right lumbar region at a junction. No guarding, no rigidity, no rebound tenderness. PRPV not done for obvious reasons. Sent for urgent USG. So that tells us that all of us to deal with an emergency should have one center closer to our clinic where urgent USG can be done and you can speak to the doctor who is doing sonography even before the report comes so that you can take action. 20 minutes, we got to know there is a right adnexa mass. I asked any free fluid, any possibility of torsion. They said no free fluid. I wanted to rule out rupture of any chocolate cyst. They said yes, it could be torsion. Now the bigger difficulty started. Referred to a tertiary center. And again, as I have a habit, when I am referring a patient who needs urgent care, I don't waste time in writing notes. This place was around 6 kilometers away from my clinic. I called the hospital, spoke to the casualty officer, and explained to him what patient I am sending. We took the patient's phone number, and after 5-7 minutes of they having left, we prepared a detailed referral note and we WhatsApp to them. Now communication skill came up. Of course, we informed the hospital. Now convincing the parents in Dubai that this young girl may require surgery. The relative who brought her, he developed cold feet. He says, no, I'm not taking responsibility. Let them come from Dubai. I said, you cannot wait like that. It could be a torsion and then she will have to be operated within an hour only. So speaking to the parents and they saying, the first question was, is it dangerous to life? I said, I can't tell you today. If it ruptures inside, yes, it could be. Will it affect her fertility? I said, I can't tell you. If it's ovarian torsion and it is corrected is okay. If they have to remove one ovary, then fertility will drop 50%. In no way you can wait till we come. I said, no, in no way we can wait. Even if you give me a consent from there, it is for your daughter's benefit. And we admitted the child in the hospital. It was a right paratubal cyst. They did a CT scan in the hospital before putting her on table. This is the picture from the OT. Right paratubal cyst. There is a left parafimbrial cyst. And both of these cysts were removed. Cystectomy was done. They said if we had not operated immediately, maybe in an hour or so, it would have engulfed the ovary and caused ovarian torsion. As of now, only cysts had undergone torsion, and that is why the pain was so acute. It's not that the cyst had formed over 10 minutes. It had gone through a torsion. That is why it was so acute pain. Ovary not involved. Since right cyst was big, there was a risk of ovarian torsion, but fortunately that was prevented. She was discharged in 48 hours. This tells us about the importance of communication skills. We have to learn. I have said once before, also maybe several times, we all have to learn how to ask sensitive questions about sexual practices. And if you are practicing in an area where you don't have totally English speaking people, then how to ask these questions in the local language. Because this can make a big difference in practice. And secondly, how do you convince people of such a decision? Now, I'm sure all of you will agree that if you had a patient where you have to convince an unknown patient of undergoing surgery with parents not here, that time, I think it is only our conviction in what we are advising convinces the other party that yes, this is required. If we are not sure, if we are not very clear about what we are suggesting, then we will not be able to convince. Dr. Mulchandani is asked, DD ectopic pregnancy. That I have not mentioned because the girl was very clear she was not sexually active. Otherwise, ED ectopic pregnancy is the first diagnosis, irrespective of LMP. But because she was not sexually active and that history had to be asked for me to move away my doubt from ectopic. Case 3. This is the case where I said I have a habit of always making a patient lie down. 1992, I had just started preparation for my Part 1 DNB. 14-year-old boy with fever, cold and sore throat. My habit of asking the patient to lie down. I examined the patient, throat was mildly congested. So I asked him to get up. Mother rushed to support him to sit up. I said, wait, why are you supporting him? No, he's weak, he cannot get up. I don't believe in the concept of weakness in a patient. Unless I'm thinking of dehydration, electrolyte imbalance, stroke or whatever. Then I did a neurological examination. We don't do neurological examination in every sore throat. Power 3/5 in both lower limbs, 4/5 in both upper limbs, cannot get up on own, trunk muscles weak. This child was immediately referred to a hospital, diagnosed Guillain-Barré syndrome. By the time he reached the hospital, which was about 1 hour later, he had started difficulty in breathing. He was in ICU for almost a week. On ventilator, they had to do a tracheostomy, but recovered fully. Now in US, settled well with 2 kids. Guillain-Barré syndrome is a neurological disorder in which our immune system mistakenly attacks part of the peripheral nervous system. It ranges from a very mild case with brief weakness to nearly devastating paralysis, leaving us even unable to breathe. Fortunately, even the worst cases recover. I've had patients who have remained in ICU for 40-42 days, but eventually recovered. Some people may have some weakness, but then they can continue with their daily life. They are not dependent on others. It can increase in intensity over hours, days, or weeks. So all of our colleagues who believe in giving vitamin injection to patients with fever who complain of weakness, please think, find out the cause of weakness. In these cases, the disorder may be life-threatening. If it interferes with breathing, if you have a patient who is a known case of hypertension or heart disease, this could become a life-threatening condition. There is another condition similar with a sore throat that we must know about. It occurs in children. I don't know how many of you had cases. A child is brought with severe pain in lower limbs. One mother said, "Doctor, he could not walk this morning. He was crawling around the house." That's a very typical feature of viral or post-viral myositis. It's a benign condition. Acute childhood myositis is the mild and self-limited sudden onset of lower extremity pain during or following recovery from a viral illness, most likely upper respiratory tract infection. Presentation includes refusal to walk, rarely tiptoe walk, or crawling, secondary to symmetrical bilateral lower extremity pain that resolves quickly within 3 to 4 days' time. If you have a case, how do you confirm? In general, no investigation needed, except in severe cases, we do screening blood work, or even to your not severe, I would always do in every case to confirm SGOT and CPK. Urine myoglobin I have not done here so far, but in 7-8 cases that I have seen, I have done SGOT and CPK. Both are elevated. That shows muscle involvement. I must tell you all that if you give an intramuscular injection today, now at 6 o'clock, even for next 12 to 18 hours, CPK levels remain very high because that muscle has damaged that injection has damaged some muscle fibers. So if the levels are very high or urine myoglobin is positive, that calls for hospitalization. This treatment is symptomatic. You can give just ibuprofen without paracetamol and total rest. These children should recover, but always first find out, is the child immunized or poliomyelitis or not. Prognosis is excellent and management might include rest and analgesia. This case is to tell us, or at least it taught me, if a patient has been investigated thoroughly 6 to 8 months back, and today we have a suspicion of the same lesion, we should not rely on the old report. This is an 85-year-old female, diabetic, hypertensive, CKD, creatinine 1.63, 1.69, morbid obesity. She is on relevant medications, including Atrax 10 BD for senile pruritus. She came with 99.5 fever, severe body pain, burning in urine, itching increased, and loss of appetite. I saw her, there was no rash. So I asked for some basic investigation. There was no nausea, vomiting, bowel movements were normal. Being a CKD patient, we advise them monthly CBC, creatinine, and potassium. Of course, she has not done monthly, she has done every 3 months. So you can see from 17 April 22 to 29 March 23, generally last 3 readings, WBC is slightly raised. Otherwise, she is normal. Now, we ask for a CBC, 11.6 hemoglobin, WBC 9450. Dengue was negative. Since it was 1 day only, I asked only for NSV, not IgM. I asked for CRP also, just to see whether any inflammation is there. It was 20.3, not very alarming. And the creatinine was 1.63, which was like her last creatinine, nothing worse. And the urine test showed all normal, 5 to 6 pus cells, but it showed bilirubin positive. Now, normally, nowadays, reports don't show bile salt bile pigments. It said bilirubin positive. And since there was no symptoms, we asked for a liver function test. Liver function test next morning, bilirubin 4.2, direct 3.21, indirect 0.99. So it is hepatic pathology. SGOT, SGOT lower 119, SGPT 186. For this to be infective hepatitis, with a bilirubin of 4.2, you would expect SGOT, SGPT in excess of 1000. So this gives an idea that it's not viral hepatitis. Gamma GT is very high and alkaline phosphatase is high. Alkaline phosphatase is almost 3 times the upper limit of normal. 116 is upper limit, 3 times is 348. It is more than that. For alkaline phosphorus to be significant, it should be 3 times the normal value. This suggested obstructive jaundice. So that explained her increased in itching, but there was no rash. This lady was hospitalized because she had mobility issues, and 6 months back, she had undergone an MRI for a suspected lesion in the hepatobiliary system, which had turned out to be normal. So I told the family that it's better we admit, because ultrasound may not show anything. Ultrasound showed query obstruction in bile duct, query calculus. This case I am describing, she is still in the hospital to undergo procedure tomorrow. MRCP done, which said no calculi, query SOL. Today, PET CT was done. and PET-CT confirmed 3 lesions. Now they will do biopsy. This is the picture that the consultant has drawn, that in the common bile duct, there is sludge or there is obstruction. They cannot make out whether this obstruction is due to the tumor or it is due to a stone. The gallbladder has 2 stones. So today they are going to do ERCP, and through that they will do a biopsy of this lesion. But they are almost certain that it's malignancy. So the lesson I learned and I'm sharing with you is, like in ECG, we always say even 1 week old ECG and today chest pain, you have to repeat. Even in major conditions, a negative MRI for SOL. Now see, 6 months only, this has come up. And what was the clue to do all this? Bilirubin in urine. And when I had seen her, she didn't have liver enlargement, she didn't have icterus, because I saw her, I examined her fully. So in obstructive jaundice or in even viral hepatitis, you will have a sudden rise of bilirubin. Tips: first, how to ask questions about bleeding PR and arrive at some conclusion before you order an investigation. Blood coating the well-formed stool. These are all very likely, it's not 100%, but source distal to sigmoid colon. In sigmoid colon, the stool is well-formed. If it is coated with fresh blood, then blood is coming from the part which is distal to sigmoid colon. Red blood mixed with stool, source proximal to sigmoid colon, could be anywhere, ascending, transverse or descending colon. Melena, tarry stools, source proximal to cecum, small intestine or upper GI tract. Maroon colored stools, source distal to small bowel or ascending colon. So it is transverse colon or descending colon. Why maroon? See, second column is red blood mixed with stool, because this is most likely proximal to sigmoid colon, because the stool, water is getting absorbed in the colon. Maroon is actually fully mixed. Then we say red ascending colon or just distal to small bowel. And bright red blood without change in vital signs is anorectal source, piles or fissure. Fissure will have pain, otherwise piles. Tip 2. Patient comes with a swelling and pain in small joints of the hands, and you have to decide which patient I should suspect rheumatoid arthritis. There are 3 joints there: metacarpophalangeal joint, the joint at the base of the finger, proximal interphalangeal joint, and distal interphalangeal joint. DIP joint, distal interphalangeal joint pain, is a common symptom of osteoarthritis, and it is known as a Heberden node. Commonly osteoarthritis, and if the patient has psoriasis, it could be psoriatic arthritis also. Heberden nodes are osteoarthritis of distal interphalangeal joint. There is nothing you can do other than relieve pain, but you can assure patient on one thing, that your mobility will never be lost. Even if the patient is a painter, he or she will be able to paint. It's only the swelling outside, the mobility of the joint is not lost. Bouchard's nodes are bony enlargement of the proximal interphalangeal joint. They also may be present in rheumatoid arthritis. Then rheumatoid arthritis tends to involve small joints of the hands. Most commonly involved joints are metacarpophalangeal joint and proximal interphalangeal joint, especially second and third MCP. That means index and middle finger. So when you have a patient like this, you should ask them to first place hands on the thighs so you can look at the entire small joint structure. Then you start palpating each and then you start checking the range of movement. So the tip is proximal distal interphalangeal joint, always OI. Only PIP, no MCP, OA. And PIP with MCP, RA. And then if you have only PIP or only DIP, no point in doing CBC, ESR, RA test, etc. Tip 3, weighing scale. I don't know how many of you actually weigh every patient that comes in. We have a habit, we have 2 cabins and we have a weighing scale in the waiting room. So one patient was diagnosed. It was little horrifying. He came a week back with gastroenteritis and we weighed him 69.5 kilos. He came a week later saying my motions and vomiting have stopped, but I'm feeling fatigued. We weighed him for 67.5 kilos. The same machine, 2 kilo weight loss in a week. He was 67-year-old diabetic, well controlled. Then we started investigation. Turned out to be a gallbladder malignancy. I do not know how every one of you keeps the record in the clinic, but I feel weighing people each day in addition to vitals does not take much time. This record can sometime save your patient. This patient of 67 years is most likely going to get cured. His son was in Ahmedabad, so he went to Ahmedabad, got operated. Now chemo going on, but the surgeons have said that it has not spread anywhere else in the body. So weight checking is not only for somebody who has come to you for weight loss. Please, a tip. Last tip is refer a patient, but keep in touch. I have had 2 cases which I still regret. One was my own nephew. He had come from Ulhasnagar to Kalina to see me with a backache. And his wife said that he's lost weight, about 2 kilos in last 3 months' time. So I sent him to a friend of mine who's MCH orthopedic from London. X-ray was done, which was normal, LS spine. And I had done a CBC ESR before. ESR was 88. So I trusted my friend. He sent him back with some medicines. And I never questioned again. I thought if he's gone back and he's not reported anything, he must be fine. He came back to me 3 months later with weakness in both limbs. That time a CT scan was done and his T12 and L1 vertebrae had rotten. He had to be operated by the legendary Dr. Bowdekar. His bone from pelvis was taken and fitted in the vertebrae. He remained in bed for 4 months. Of course, today he is fully normal, but that is one regret I always have, is after referring, you don't follow up. And when I asked that doctor again, my friend, he says, I did not do the CT because I thought there's nothing. I said, yeah, but ESR was 88. I couldn't blame him also because he had spent 15 years in London, not seen a single bony corpse. Second case was a patient who came to me for recurrent vomiting. My own patient. I referred him to a gastroenterologist who I knew, who's been treating my patients. I said, please do an endoscopy and advise. And I forgot about it. See, when you refer a patient, no, patient thinks that my doctor has referred, no, so now I can trust this doctor fully. This patient came back to me in about 4 to 5 weeks' time, and I couldn't believe what I was seeing. He had lost around 12 kilos of weight. Looking at him, I thought he's got a malignancy. So I asked him, what happened? I have been going to that doctor. My vomitings have not stopped. I said, you should have phoned me, no? No, but I thought you only have sent me there, no? So I did a chest X-ray. And that chest X-ray showed a huge shape in the center. He had a psoas abscess, which was pressing on the esophagus and causing the vomiting. And gastroenterologists had not thought beyond the GI system. Fortunately, we had a very good spine surgeon who treated him conservatively for 18 months. And this man also is fine today. He had come to my clinic yesterday. So today I have a habit. If I have a patient in a hospital, I must speak to the concerned doctor at least once in a day. If the patient is critical, twice in a day. So a request to all of you, if you refer a patient, never lose touch. Jokingly, it is said, don't offer. I'm going to say something here which some of you may not like. See, we all have different types of practice. One doctor told me that you keep telling us to keep in touch with the patient or the consultant. He practices in an area where generally revenue sharing is done. So he says that our consultant tells us, why are you concerned of diagnosis? You are getting your packet. No, I said, no, that is wrong. No, your patient should not be fooled or over-treated. No, you have a right to diagnosis. You may want to take whatever, that is immaterial. I am not sitting here to do my judgment on that. But then you should never lose your touch, because your patient will think, my doctor has said, so I have to trust this doctor now. That's all for today. There were some questions. Any prodromal symptoms? Vinita Kaushik saying I have diagnosed early GBS in my husband and a decade ago. He is fine now. Yes, Dr. Vinita, I must congratulate you. Dr. Pallavi Khare is saying any prodromal symptoms or any clues which can help us to anticipate GB syndrome? No. From the patient, the problem will be only weakness. So I always say, if the patient says I'm weak, no, respect that word. Replying to any prodromal symptom, fever with progressive weakness of limb. Many times you may not even get fever, you may just get weakness of limbs. CPK tells you about muscle loss, but CPK will not be elevated in GBS because it is a autoimmune nerve disorder. Yes, respiratory or GI infection, but most likely viral. Test in viral myositis, CPK, creatine phosphokinase, and SGOT. SGOT is specific for muscle, SGPT is specific for liver. So we don't do SGPT, we do only SGOT. CRP always little and a CKD patient. Yes, I still did it because, if it had come 80, 90, 100, then I would have suspected that some another inflammation is going on. Obstructive jaundice, yes. CA causing obstructive jaundice, yes. Cholecystitis would have been acutely painful, which this lady did not have. MRCP or ERCP both can be done. Alpha fetoproteins can be done if we had seen some lesions on ultrasound, then you can do alpha fetoprotein. But the history with which she came, that acute rapidity, I think it was pointless doing alpha fetoprotein. It had to be proven on imaging. Diagnosis TB spina, psoas abscess. Both the cases I said, which I regret, were TB spine. One where the bone was affected. Secondly, bone was not affected. The pus had formed. Rohit Kumar is saying consultants quite often do not oblige talking or discussing. Rohit, in India, we have a right where we want to refer, and I insist on that. Even in a tertiary care hospital, I say that I must have a call from the surgeon as soon as surgery is over, because what happens, surgery is over, I have sent there, because he's my friend or I know him well or he's a good surgeon. Relative will call me, sir, surgery over, you must have got a call. So I insist on that. Rohit, I don't know about US. Mukesh Desai, Mukesh Patel, subscription 1st October for sure. Yeah, many consultants not interested in talking, then you should not be interested in sending to them. Dr. Oswal is, Preeti, please share the Telegram link, no? Dr. Oswal, put your number here. Preeti will connect you. Thank you very much. So I think we will continue. psoas abscess patient had no fever, no pain, only vomiting. Because see, there was the thorax, for the thing to spread, there was place. It was only pressing on the food pipe. Case to 15-year-old, yes, DD can be appendicitis. Appendix, salpingitis, hemorrhagic cyst, all were DDs. So we'll continue once a month. Rohit, you are talking of Indian consultant. I think I tell people don't send. Even if you are getting a packet, don't send there. So once a month, we will do cases and some tips. Viral myositis, good electrolyte supplement helps? No, it is a self-limiting condition. Dr. Nilesh Shetty is telling me you showed some boldness here. See, we know everybody practices in a different way, and we are not sitting here to pass our moral judgment. My idea is this, that patient should have the first option. Thank you very much. More time for your practice. Bye.